In this chapter, we're going to look at drugs for treating musculoskeletal and neurological conditions. So we're talking about a lot of neurological conditions in the pathology portion of this class, but we're going to look here at some specific drugs that can be utilized that you'll see for certain conditions. There's also going to be mentioned, because again, the tie-in with the musculoskeletal system, there's some other drugs that some of which we've already talked about, but we'll kind of make mention. So for instance, there's going to be some reference to corticosteroids and NSAIDs because sometimes they get utilized. But we're going to talk about some other drugs for musculoskeletal conditions that aren't necessarily like sports medicine orthopedic type injuries that you would typically see in like an athletic setting. So again, the AT can provide care for a range of different conditions. So again, there's a reason why we teach about pathology, is because, again, as part of your assessment, you always have to make sure that you're always kind of keeping in mind, some, non-orthopedic causes of injury or non, athletic type or injuries as a result of activity. So obviously, any type of articular pain or arthralgia, pain within a joint, is obviously something that we commonly run into. Now, as far as like the the medications and stuff like that and the causes of it. So again, typically what we're going to see is obviously joint pain or injury caused by a particular trauma, but there's also various types of, again, non-athletically related injuries and conditions that can occur. So just some other terminology. So periarticular is referring to pain from the tissue surrounding the joint. Monoarticular pain is a single joint, or polyarticular is systemic. And obviously, one of the things that we need to be aware of is when individuals do have pain at more than one joint, that's when we start to get a little bit more cause for concern for there to be systemic, or again, like more of like a non-orthopedic kind of cause of their pain. So we're going to be kind of looking at some different things, particularly when we look at things like rheumatic diseases. We'll talk briefly about like a rheumatoid arthritis. So a rheumatic disease in general, you probably heard of rheumatoid arthritis. That's a form of a rheumatic disease, but it's a group of autoimmune conditions. So again, an autoimmune condition is when the body's immune system attacks itself. In the case of what a lot of the things we're going to be talking about here, we're going to look at autoimmune diseases that attack the musculoskeletal system. So you could have, the joints could get affected, the muscles could get affected, the bones could get affected. So there's different types of disorders that can occur as a result of various rheumatic diseases. There's acute arthritis that could occur. So in the case of an acute arthritis, you're usually looking at an infection in a joint. So one of the more common causes of an infection around a joint is you can actually get MRSA can go into a joint, and that could be MRSA that started out as a superficial infection in the skin, and that could go into the joint. So typically what you'll see with this is like a really acute, very sore, swollen, warm joint. And again, it could be caused by, MRSA is one of the common things we would see, but there's obviously other bacteria that you can do this as well. Osteomyelitis is an inflammation secondary to bacteria in the bone. Again, not common, but as an athletic trainer, you need to be aware of the signs and symptoms of osteomyelitis. So again, any type of localized peripheral bone pain, if they have fever, malaise, tenderness, those would be some things that, an individual, could possibly have an infection in the bone. Again, it's not a common thing. Usually it's going to be spread from, again, infected tissue, so an open wound, particularly if there's an open fracture. So that's one of the obvious big concerns when we talk about open fractures and why that has to be handled the way it is to make sure that an individual does not get that infection in the bone. And then there's gout, which we have talked about already. Here we're going to kind of look at, again, what it is and some of the issues. So this is when you get that hyperuricemia causing uric acid crystals to form in and around the joints. The illustration in your text shows one of the more common areas where this occurs. So classically, you tend to get this at the first metatarsal phalangeal joint extremely painful. Anyone who's ever had gout will tell you that it is very painful. So the initial attack is usually going to hit typically in that first metatarsophalangeal joint. It can occur in other joints around the body. For instance, it could occur in like the wrist. And again, they'll get that severe pain, tenderness, warmth, redness in and around the area. And usually with the diagnosis, you can't actually like see crystals in the actual synovial fluid. So this again is a very, very painful thing to get. So again, looking at those particular conditions as it relates to the joints. So again, for septic arthritis, there's going to be IV antibiotics in severe cases. So, and depending upon the type of bacteria, so usually they're going to try to get a sense of what type of bacteria is actually causing the infection. So in the case of a gram-positive bacteria, they use vancomycin, gram-negative bacteria, cephalosporin. So those are different antibiotics. So again, prompt referral. If an individual from kind of like out of the blue gets this like severe pain, even if it's just in one joint, and it kind of came out of nowhere, and the joint's very swollen and warm, chances are there's a good chance there's an infection in there, and that needs to be treated pretty promptly, diagnosed and treated very promptly. Osteomyelitis, you will, again, inflammation and destruction of the bone. Again, that's going to require surgical debridement and an IV antibiotic for 4 to 8 weeks. So again, there you're looking at some examples of some of the different antibiotics that could be utilized for that. For gout, you can utilize NSAIDs or colchicine, which is a particular medication that gets utilized for gout. And the way colchicine basically works is it binds to neutrophils, and what that does is it basically doesn't allow the cells to migrate to the areas where the uric acid crystals are. So what that effectively does is temper that inflammatory response. Again, here you're not dealing with an inflammatory response. Like we always say, be careful how much you suppress the inflammation response when you have an injury. In this case, the inflammation response doesn't really serve a purpose. It's basically happening because of these uric acid crystals forming and causing inflammation in the joint. So colchicine is basically going to prevent that white blood cell migration, and then that's going to kind of temper the inflammation response. NSAIDs are going to be typically taken at fairly high dosages because it's going to be specifically for the anti-inflammatory effects when you're dealing with gout. And again, it is a very painful condition to deal with. So you really want to make sure that the individual gets referred to, and they'll probably want to go to a physician for that because they will be in a lot of pain. Osteoarthritis, again, is probably something that in sports medicine settings, again, in dealing with a younger population, you're not necessarily going to see. However, if you're in a more non-traditional setting, you're probably going to encounter osteoarthritis, and again, you're going to be getting that inflammation and destruction of the bone. So here you're going to have loss of joint cartilage. So this is kind of that degenerative arthritis, that can occur for a variety of reasons. Overuse, maybe a person had a specific type of surgery, and as a result of the surgery, it's kind of something down the road that can happen. It's just a degenerative joint disease, effectively. Typically your your treatment for that is basically going to be a lot of over-the-counter or prescription medications, anti-inflammatories, when you're particularly looking at osteoarthritis. There's topical analgesics that can be utilized as well. A lot of individuals will potentially utilize them. If those aren't successful, again, there's various NSAIDs that can be used at higher dosages. Another thing that can be utilized is hyaluronic acid joint injections, which basically help to stimulate synovial fluid formation. So hyaluronic acid is just a component of synovial fluid. So the idea is when you inject with the hyaluronic acid, it allows the cells to produce more synovial fluid, and effectively what you look to do is that Usually about 2 injections over the course of a period of time usually seems to work fairly well for this. We talked about some other supplements, things like glucosamine are also something that are very popular for individuals dealing with arthritis. Now, rheumatoid arthritis is a little, again, a little different. The reason for it happening is, again, it's an autoimmune response in the body. So what basically happens, again, anytime we discuss autoimmune diseases, it's the immune system becoming overactive. So again, one of the some of the medications used for this will be to specifically suppress the immune system. So obviously the side effects of that is you potentially render yourself more to other types of illnesses, but again, in an effort to kind of suppress this response, which could become pretty debilitating, it's very important to kind of do that. So it's the kind of give and take there. Again, you're going to get synovial inflammation as a result of this, and what's going to happen is the joint fluid's going to erode, and typically you're going to get many times people with this kind of down the line will get severe swelling and deformity, and where you will typically see this, probably being the most dramatic is in the wrist and the hands. So the wrist and the MCP joints will get very inflamed. Again, the treatment here is to just reduce inflammation in any way possible. So some of the options, and again, these are just options for you to be aware of and be able to recognize. So the disease-modifying anti-rheumatic agents. So these, again, are specifically to suppress the immune system. So methotrexate is one of the more common DMARDs that are available. So again, the idea here is to basically administer these and with the intention of suppressing the immune system. NSAIDs can be delivered here. They have limited utility. And the reason for that is they don't prevent progression of the disease. So these can be used as an adjunctive medication, primarily just for like symptom relief, but they're basically not going to prevent any erosion. And again, you have to also weigh the risk, the pluses and minuses of taking an NSAID. You may be given, and one option is to do a low dose of corticosteroids, particularly for an individual with polyarticular syndrome. So low dose systemic corticosteroids can be added, and this can be done as well. You can also do intra-articular injections with corticosteroids, but again, you have to be aware of that with chronic use, that there can be severe side effects with that. So that's primarily what you would look at. Another potential option, and this is discussed in your textbook, is hydroxychloroquine, which is actually an anti-malarial drug. That's another medication that has been used in rheumatic disorders. And again, there's non-pharmacologic options, and that's everything from rest to, in some instances, you may have to the individual may have to have surgery depending upon the degree of the joint disease and how much deformity at the joints start to occur. So looking generally at musculoskeletal pain, again, we're looking at common, periarticular pain again, associated with active movement. These are things that we're more likely to see in a lot of, again, our more conventional sports medicine settings. Obviously, our expertise allows us to work in other what we call non-traditional settings, but in most of our work settings, so things like tendonitis or tenosynovitis. So like we start to look at some of the more common soft tissue injuries and some of the pain and inflammation associated with them. Again, be aware that, again, if a condition isn't caused by inflammation, again, anti-inflammatories will work particularly as it relates to pain, but they're not going to do anything if there's no inflammation present. They're not there. So interestingly enough, again, here we go with tendonitis, and we're saying tendon inflammation, whereas we know many times when individuals present with a tendinopathy in sports medicine settings, they don't tend to actually have inflammation. So yes, in a true inflammatory tendonitis, the anti-inflammatory medications will work, but as we know, that's Usually not the case. A tenosynovitis, there will be some inflammation. So really here you just look at, for the most part, we'll talk a little bit about injections and why injecting tendons themselves are not a good thing. But over-the-counter NSAIDs for, or acetaminophen for 5 to 7 days is just kind of a common thing you'll see. Again, when we start to talk about like actual, joint injuries and stuff like that, that's where the corticosteroid injections will have a little bit more pertinent. But typically you're not going to inject a tendon with a corticosteroid because that can actually delay soft tissue healing and can actually weaken the tendon a bit more. So that's typically why you're not going to see, at the very least, frequent tendon injections, because we know that it could predispose an individual to ruptures. So again, continuing with that same loop, again, corticosteroid injection, there needs to be the significant guidelines that we look at this. Again, if you're going to inject for a tendon condition, usually they look at injecting it into the tendon sheath. So again, a skilled practitioner really has to do this. So injecting into a tendon sheath, you're usually not going to have as many problems with the actual weakening of the tissue that you'd commonly see as you would with other things. But you do have to be aware of that. Any excessive injections could weaken tissue and predispose to rupture. So you want to make sure that individuals are not getting repeated injections, particularly into tendons, because of that issue. As far as the choices, betamethasone and methylprednisolone or methylprednisone are some of your more common options that you're going to see. And again, the dosages, so betamethasone about 6 milligrams per milliliter, methylprednisolone 20 to 80 milligrams per milliliter are going to be your common options. Again, it's usually going to be indicated if the pain is severe and like the problem has been chronic. Again, you want to make sure that you're careful not to inject into the tendon, which could weaken it. Again, that could sometimes be hard, even in a skilled practitioner, to do. And again, they should always be made aware of the risk of tendon rupture. So resting the tissue is essential after the injection. And again, that's just because the initial, right after the injection, is when they could be most predisposed to rupture. And many times what you're going to see is that symptoms can actually worsen, and you could actually even see this in joints. If somebody does get a corticosteroid injection into a joint, it's not uncommon to see like a post-injection flare-up. So pain after the injection that gets worse for the first 24 hours is not terribly uncommon to see. So many times, to kind of suppress that, a physician will add a little bit of lidocaine to the injection. I know the team physician I worked with, for certain injections, he would mix in some lidocaine, and that would typically, suppress some of that, or at least not make it quite as sore later on after the injection occurs. So looking at neck and back pain, because this will kind of tie into, even again, some of the neurological system and issues related to nerve pain. We know that neck and back pain is very common. Obviously, when you look at this, you're trying to determine, is it muscular pain, or many times do you have a concurrent radiculopathy? And obviously, that's something to kind of be aware of, because that does kind of change it a little bit as far as how you can treat it and how irritable the condition is. The concurrent radiculopathy, if somebody does have some type of nerve root getting impinged for whatever by some structure in and around the spine, that becomes very problematic, and that's probably something that we want to look at. In general, again, you're going to see these are obviously some of the symptoms you have. Again, you want to be aware of the radicular pain. Radicular pain, weakness, numbness, that's when we know we have a little bit more going on that we need to be aware of. Those are kind of like some red flags that we need to kind of find out what exactly is causing that. So again, various therapies, it really just kind of depends upon, the individual and what structures are being affected. So obviously, if they have a radiculopathy, that's something to be mindful of. Again, if they have impairment in, sensation, in strength, if they have, other neurological deficits, like, again, you're going to want to do a full neurological exam, as we talked about in pathology, reflexes, dermatomes, myotomes, to make sure, that you're ruling out. And if any of that comes back positive, that's going to typically require more involved diagnostics. So again, some options: counter irritants. Again, these are just primarily to stimulate the basically to provide pain relief. Now, there are topical medications that will actually affect the inflammatory response, so it really does depend upon what type of topical medication you're using. If you're strictly just using a counter irritant, typically all they are is just basically like a basic pain relief. Okay, so they stimulate those sensory nerves that kind of then interferes with the pain response. Obviously, there's other types of like topical anti-inflammatories that you can use that will very specifically affect the inflammatory process. NSAIDs, so again, ibuprofen, naproxen, can all help to relieve things. Again, typically, if the concern is that they're treating inflammation, they will typically be given at slightly higher dosages. A muscle relaxant can be given if there's a lot of pain and spasm. Many times this is given in cases of non-specific low back pain. They should really be restricted to patients with severe muscle spasm and severe pain. You don't want to just, muscle relaxants should sort of be like more of like a last sort of resort for individuals. If they have, a lot of muscular pain, muscle spasm, they're having difficulty sleeping. Flexeril or cyclobenzaprine is probably your most common muscle relaxant that you'll see many times getting prescribed for individuals here. Again, corticosteroids can be utilized if a person has severe radicular pain. They'll usually recommend a course of oral corticosteroids before injection. If an individual needs an injection, particularly in and around the spine, they're usually going to get referred to a specialist for that, because if they need an epidural injection, that's something that requires a person with specific expertise in that, and usually that's done through diagnostics. I've heard of some physicians giving epidurals without that, and that is a risky process to undertake. Antidepressants can be utilized in the cases of chronic low back pain or radiculopathies. So selective serotonin reuptake inhibitors and norepinephrine reuptake inhibitors, which are typically used for people with depression. So Cymbalta is an example of that. There has been some benefit. There's not a ton of evidence, but it is something that can be utilized. Again, typically they'll go to that if some of these other things haven't been effective. If somebody has non-specific lower back pain, which some people don't even, I personally tend to not like that diagnosis, but sometimes you can't find a cause, and in that case, something like this might be a little bit more beneficial. Opioids, again, because of their potential for addiction, these should only be used for a very short period of time. So, again, and this should be, again, a little bit more extreme. The person's in so much pain they can't sleep, which if that's the case, hopefully, other, diagnostic studies have been done on them to rule out things like cancer and tumors. But, in a short term, opioids can be utilized in this situation. So turning to a condition, very difficult to treat, fibromyalgia, which is a form of myofascial pain syndrome. And it's basically a non-articular disorder of unknown cause. There's some theories as to why it occurs, but there's not a particular etiology that you look at. And basically what you look at, the people that present with this tend to present with widespread kind of aching muscular pain. It's kind of widespread. the American Pain Society actually has kind of like diagnostic criteria for this. There's some pictures of it in your book, kind of showing that there could be some other kind of issues associated with this. So there's cognitive impairments that sometimes occur with this, and some psychological issues that many times tie into it. Not always, but sometimes do. There's actual specific what they call tender points. So if you kind of go throughout the body and lightly palpate these different areas, and there's specific what they call tender points that when they have an individual has this, that kind of goes towards the diagnostic treatment of fibromyalgia. But there's some other things. Take a look at some of the other systems that sometimes do show issues related to this. And again, sometimes it could just be related to like even just like overuse. Some people can develop this as a result. So it does kind of have different manifestations, I guess is a good way of putting it. And this is part of the challenge in treating it, is that there's different ways that people present with it. And many times it'll kind of come down to like a differential diagnosis, like people will have other systemic conditions kind of ruled out, and then we'll come to this diagnosis. So what are the options? And again, there's various things. There's no single best choice, because as I said, individuals present with this so much. Like some individuals will literally just have what just appears to be a lot of musculoskeletal pain, and they won't have anything else. Or you'll have individuals that maybe have some more systemic things happening, stomach issues, depression many times gets associated with this, which some of the, again, depending upon who you talk to, they debate is the depression part of the fibromyalgia, or is it caused by the fact, obviously like after a while when you have this widespread pain, you tend to after a while get depressed and frustrated. So it's one of those things, and again, depending upon who you talk to, there could be some different ideas behind that. But just know that is something that does occur, so it can be challenging. So obviously, again, acetaminophen or NSAIDs can definitely be an option here. Sedating drugs, again, the antidepressants can be utilized as well. Tricyclic antidepressants like Elavil or something that can be utilized. Another thing, just because it does have a sedating effect, is the Flexeril, the cyclobenzaprine, which is a muscle relaxant, that can also be kind of utilized as well. There's no evidence here of opioids having really any utility. So they probably should be avoided. And in particular, if you do start to kind of look at individuals maybe having like some, psychological depression, things like that, that could be something to be aware of. Analgesic injections into the areas of tenderness are obviously also an option. So, lidocaine or bupivacaine is another thing that can be utilized. They should not be relied on as a primary treatment, because there's not a ton of evidence to show that they work, but it is another option potentially. So as you can see here, a lot of widespread. The other thing is, again, ways to improve sleep, which again, the antidepressants and the muscle relaxer could help with that. Stress management could be really important. So, and you may need counseling for it if there's associated depression or other mental health issues with it. Another complex thing to treat is complex regional pain syndrome. At one point, this was referred to that it was called reflex sympathetic dystrophy. So some people may still call it that. That's kind of like an outdated diagnostic name. Complex regional pain syndrome is the more accepted name at this point. Again, here we look at neuropathic pain, typically following a soft tissue bone injury or even like a nerve injury, that basically ends up lasting longer than expected. And what ends up happening is the pain that the individual experiences is actually beyond what the level of tissue damage is. So essentially what happens is somebody has an injury, and for some reason the individual just gets these prolonged symptoms, and it's just basically believed to be basically a dysfunction in the nervous system as a result of this. And typically what, again, kind of the classic signs and symptoms, the person will have this, neuropathic pain, and again, the pain will be longer than the original, what the original injury should be. So take whatever common injury you see, and it basically lasts longer. The person has a lot of increased sensitivity to the affected area, what they call allodynia. So like normal contact with the skin causes a lot of pain. You may also see the individual, their skin may change color and get blotchy. That's kind of another thing that you will commonly see with this. So, and you have to be aware of this. I've actually seen, there's at least one case of this I could remember an individual getting, but you do have to be on the lookout for it. Because if if a person really starts to seem like they start to get really sensitive to things after if the signs and symptoms aren't kind of like lining up with the severity of their injury, that's going to be something important to be mindful of. So again, your treatment options, again, NSAIDs, these will generally be your first line of option. So opioids might also be an option if, in appropriate doses for controlling the pain, because if the pain is that bad, it needs to be dealt with. Again, your antidepressants, anticonvulsants can also be used as well. So we haven't talked about anticonvulsants yet. Gabapentin, also known as Neurontin, is used in this. So again, gabapentin can be used in various types of nerve pain. So again, that's an anticonvulsant, but it's been used to treat other types of nerve pain. Corticosteroids can help in reducing any inflammation present. Some individuals will get nerve blocks. So basically they'll get anesthetic injections to basically block the pain fibers to kind of limit this. Anesthetics can also be used, sometimes either low doses of IV or intranasal ketamine, which is a really strong anesthetic, may alleviate pain. So, however, again, that'll alleviate the pain, but it doesn't improve function. So, part of what goes on with therapy with these individuals is they'll go through and gradually have to start to sort of get used to touch and things like that. So, just a real simple example of treatment for this, you'll literally take like different types of materials that have different surface areas, and you'll literally try to get the person used to having their skin get touched again, because something as simple as just a rough fabric or something touching their skin causes severe pain. So this is something to be mindful of. You also have to watch what types of modalities you use on these people. Again, even if it's not like a specific contraindication, there's just some modalities, because of the fact that that the sensation that they give is just not going to be helpful and can make the person feel worse. Headache disorders. So again, we talked about some from headache. So obviously a concussion. You do want to make sure that an individual with a concussion, when they're kind of dealing with their headaches, no aspirin, no NSAIDs, and no opioids for an individual with a concussion. So if they have a concussion, you don't want to do anything that is basically going to affect blood flow, or basically, because if there does happen to be a bleed in the area, the anticoagulant properties of the NSAIDs are going to cause a problem. So you do always have to be aware of that. And again, the opioids, you just want to make sure, because they're going to be so strong, they'll mask the symptoms. So acetaminophen is fine. That's a safe option. If a person does have headache pain as a result of a concussion, they can take acetaminophen. It's not going to cause any problem. It's not going to matter if they end up, God forbid, having a bleed. The acetaminophen is not going to stop their pain. They're still going to have a bad enough headache to know that they need further medical attention. If it's just the typical symptomatic headache that you get with a concussion, the acetaminophen will be fine for that. For a migraine headache, again, we kind of talked about the pathology of migraine headaches. Again, they're typically going to be that unilateral pain, nausea, sensitivity to light. Most patients will express that they feel that aura that they get, so they'll know that they're starting to come along again. These are very severe. They get worse with exertion. Again, you could have photophobia. So there's many options. There's over-the-counter the options. There's emergency. There's various therapies that can work for this. So if we're talking like a more urgent situation, ketorolac injections can be utilized for this. So this NSAID is administered by an emergency department. So you don't want to take this for too long. The injection might cause medication overuse headaches and possibly cause like issues with the gastrointestinal tract. So that's something that has to be utilized in an emergency setting. So if it is severe enough, or a person has gone to the emergency room because maybe they're having a severe migraine for the first time and they don't know that it's a migraine, that's where specific medication will be used. Looking at some other medications, so Imitrex, that looks to block the pain pathways. So Imitrex is actually a vasoconstrictor, so that's something, again, patients at risk for heart attack or stroke need to be aware of some issues with that, because it could cause some problems. Another type of vasoconstrictor, Migranol, or the dihydroergotamines. These are other vasoconstrictors, and again, you want to take these shortly after symptoms start. So, and again, side effects with these, you could possibly have a worsening of the migraine headache. Again, people with like blood pressure, kidney disorders, various cardiovascular disorders should be aware of this. Pregnant people should avoid these particular types of drugs. So those are all things to be aware of. Antiemetics, anti-nausea drugs, so example like a Regland can be administered as well. For tension headaches, so tension headaches are probably the most common types of headaches. These are a little bit more benign, and again, commonly what you'll see with tension headaches is they're a little bit more diffuse. They typically occur for less than 15 days. They happen for a variety of reasons. We could sometimes see that tension headaches come about as a result of like different types of musculoskeletal imbalances in and around the neck and jaw. Again, your over-the-counter NSAIDs or acetaminophen, either one is fine. Again, there could be, neither equivocally or better. Typically for ibuprofen, around 400 milligrams, acetaminophen, 1,000 milligrams will typically be utilized. Look at another thing just to be aware of is look at your sort of red flags of headaches. The textbook talks about this, and this could be, again, sometimes it's a matter of, finding these like red flags in people, and, you could save their life. So any type of abrupt headaches, severe headaches that come on all of a sudden, if they're accompanied by like stiff neck, seizures, severe double vision. This is part of the reason why many times somebody getting a migraine, sometimes for the first time, they go to the emergency room because they're just they've never had a migraine headache before. And they get one and they think it's something more severe, and they go and it turns out that they have a migraine headache. So not uncommon to have that. So look at those red flags. They talk about when neurological emergencies or something to be a little bit more, where you need to be a little bit more concerned with that. So in summary, again, there's various types of conditions, some of which we talked about, some different ones that we didn't make mention in pathology, but we got a good idea. Like, for instance, fibromyalgia was one that we didn't really mention all that much in pathology. But again, make sure to look at the drugs that are used. Again, look at the different tables in your book. They kind of discuss some of the things, the side effects associated with them, and again, when sometimes you could combine medications as adjuncts with other therapies, as we talked about. And these are your objectives.